All right, thank you everyone for joining us today. It's really great to see you. We've been talking about a special group of champions for kidney supportive care for a few weeks now at AHN. And the first topic that we're going to cover over the next 12 weeks actually is going to be symptom management. So most of you would have had access to the introduction to supportive care. If you haven't, Lydia and myself and Dr. Azael can put together a short link to the recording. We did that session the first week of February in all of our different IECHO sessions. So, and also a longer version of the session was done during the fireside chat. So we would request that you do catch up if you didn't attend the first week of kidney supportive care, because we're going to get right into our content and teaching. So this week we're focusing on symptom management, and there are many symptoms that we actually will be covering. So we've actually broken it up over 2 weeks for the champion group, and then over the next again 3 months we will be covering a different topic every week. In 2 or 3 weeks, we would love it if you guys would consider putting together a case. So the way ECHO works is that we do a short teaching time, usually 20 to 30 minutes, and then we spend the second half of the session talking about cases that are applicable to the topics that we're covering. So I'll be able to share with you a template of a case, and over the first few weeks, I'll be showing you some examples of cases and we'll be discussing them. But do think of it, think of potentially working with us, of course, myself and the team, to create a case and share. And I think that would really be a helpful way for you to learn as well. So we will start with the session now. And if you do have any questions, just put your hand up. We're a small group, and now that we've met each other, I think it would be great if you felt comfortable. You can also just put a message in the chat, or you can put your hand up and you can stop me during the session. All right, so over the next several weeks, we'll be covering kidney supportive care. To get a general understanding of palliative and supportive care, we do recommend 10 to 12 hours of teaching. And we are hoping that through this champion course, we will be able to pass out completion certificates and participation certificates to all of you. And through the course of these next 3 months, we'll also be talking about how we as a group want to begin to implement palliative care and supportive care in our workplace at AHN. So we'll be looking to you as leaders for this program to succeed. So I did want to give credit to Dr. Pankaj Singhai from India. He recently had run a training from the India Association of Palliative Care. It was a master class for renal palliative care in India, and I was able to adapt some of the content from his session. He will be teaching one of our fireside chat global webinars in several months, so that will be great too if you're able to join. We also have been able to take a lot of the content that we're going to be using in our kidney supportive care program at AHN directly from the International Society of Nephrology Academy. So the ISN Academy, they recently released a module on kidney supportive care and conservative kidney management just now in February. So you will see that some of the slides are screenshots, and that is directly from the Academy. It is a free course that all of us can complete. I was able to complete it in a few days, which is great. I know that obviously if you're working full time, you won't necessarily be able to do it full time, but each module doesn't take too long. There are about 5 to 15 minute teaching sessions, and then there's case discussion and also a quiz. And they're completing a few more modules. So this is a program that probably in the next 3 to 6 months, we would love for all of you to complete this online course. It is self-paced. So it isn't live teaching like an ECHO, but it is a really good course for our group. So by the end of this session and even into next week, we are going to be covering the following symptoms. So we're going to be looking at uremic pruritus. We're going to be looking at restless leg syndrome, nausea and vomiting, dyspnea or shortness of breath, we also call it, depression, cachexia, anorexia, and recurrent abdominal pain. So these are the symptoms that we'll be covering. We'll cover probably half of them today, and we'll continue into next week. We also will be talking about best practices. So along with each symptom, we'll talk about the symptom, and then we'll also identify what can we do and what can we talk to the team about as we think of ways to manage these symptoms. And then we'll end the session next week just to identify what is crisis planning and how do we support our kidney failure patients with that. So this is from the ISN Academy. When we talk about and when we begin to think about symptoms, suffering due to symptoms impairs the daily living and cognitive functions. So our patients' ability to live and cognitively function, their ability to sleep, and that thus impacts their quality of life. And we know from the article here shared in 2003, Managing the Symptom Burden Associated with Maintenance Dialysis, that it actually can even reduce life expectancy. In 2018, from the Journal of Nursing Science, they identified that the mean number of symptoms experienced by individuals is very high in kidney failure. And some studies ranging from 6 to 20 symptoms that patients reported. And in 2007, as well as 2018, what they observed through those two articles that are referenced there is that there's actually a high level of discordance. So there's not a lot of agreement between patients' experience of symptoms and us as nephrology care providers' recognition or even prioritization of those symptoms. So that's kind of a concern for us, especially those that are providing care to our patients in holistic care. That's something that we want to do better at, and that's actually one of the reasons why I think many of you have entered into this course. So in 2013, there was also another review of some recent literature that showed the percentage or the amount of symptoms that patients experience. And you can see on the left-hand side, they have the different symptoms, and then those that are on a conservative pathway. And here is Dr. Frank Brennan. He's a specialist from Australia. And then the final column is cut off there, but those are patients that are on dialysis. So these are reported symptoms of patients that most of our patients would actually be on the far left side. So actually all of our patients are on dialysis. And this is the symptoms that they've reported. So here you can see some of the highest symptoms are fatigue at 81%, pain at 66%, anorexia, 58%, pruritus, 61%, very high symptom burden for our patients. Those on the conservative pathway, we'll learn more about this during our next fireside chat. That's for patients who have kidney failure but choose not to do dialysis or don't have access to dialysis to choose that. They also have very high symptom burden. So they're reporting a lot of symptoms, and it does affect their quality of life. So when we think of symptoms for our kidney failure patients, these are the ones that we're going to cover. But we know actually that it begins by acknowledging that distress is experienced. And sometimes we as clinicians are not so good at acknowledging that symptoms exist in our patients. So one of the biggest ways we avoid acknowledging this is by not assessing it. So we don't ask our patients about their symptoms. And this can be one of the reasons that there is such a discordance or a disagreement between patient-reported symptoms and what we as clinicians do related to the symptoms. So I just want to take a minute, if you can write in the chat, what are some of the most common symptoms that you see in your patients? These are the ones that we were planning to cover, but I'm curious to know what are some of the symptoms that your patients report at AHN in your different clinics? So we have a good representation here. We have Rwanda, Tanzania, and Kenya, which is great. So if you want to just take a minute in the chat just to put one or two symptoms that you guys see your patients experiencing. It could be one that we've mentioned, or it could be something that we missed. I know we have a few trainers here, so you may not be providing direct care, but what are some of the symptoms that you know are quite common in our population? Okay, headache, nausea, good. Nausea and vomiting, headache, fatigue, especially after dialysis. Yep, restlessness, fatigue. Fatigue. Oh, Asha, you've introduced yourself. Perfect. Welcome, Asha. Backache, confusion, malaise, good. Loss of appetite, dyspnea, very good. So a lot of the same ones. I think we didn't have headache and maybe confusion on our list, but those are really good and obviously shows that we're talking about the same thing. So one thing I want you to know and think about and just reflect on this week is, what do we mean when we say the word symptom burden? You may not talk like this in your practice, but these are some questions, and I'll put this in the WhatsApp chat afterwards as well, for us to reflect on this week. So what is the symptom burden on our patients? How much do these symptoms actually affect their life? When we begin to consider a supportive care approach, we need to first acknowledge that actually the symptoms that our patients report can affect their life greatly. And I want to also say that as we educate patients and families about symptoms, we also support them in understanding what realistic goals are for managing those symptoms. So that's actually part of our role. That's what we are responsible for as their clinicians. So if you're taking notes today, actually, I forgot to mention, if you want to get a pen and a notebook, I have mine here right in front of me. Because we're doing this course kind of quickly every week, we're going to be talking about different things. I would encourage you to bring a book with you where you could just take some notes. Maybe write down the word symptom burden, and then how much do the symptoms affect your patient's life? Dr. Frank, in the ISN Academy curriculum, advised that we adopt a multimodal, so a multiple option or multiple ways of approaching management for our patients. So we first need to recognize and reverse the reversible causes. For example, recognizing anemia and then treating the anemia as we are able. Treating shortness of breath and fatigue. These symptoms of anemia, shortness of breath and fatigue, can be corrected if we are able to correct the anemia, and therefore then we've addressed the symptom. We also then secondly need to utilize the non-pharmacological, so not medicine, approach before and also alongside a medication if the symptoms are mild. So we need to think of things that are not medication that can be introduced into a patient's living experience, their daily life, as well as potentially prescribe some medication to support the patient. Again, people on dialysis typically experience many symptoms throughout their illness. So here's a chart. You can see the number of patients reporting their symptoms. So here the big number is the number of patients. And then we have also here the symptoms being tired, their well-being, their appetite, pain, itchiness, drowsiness, being anxious, shortness of breath, and nausea. So here we can see that on average, again, our patients have between 6 to 20 symptoms, and that's really high. If you think of having the common cold, maybe you have 2 or 3 symptoms. Maybe you have a fever, you have a cough, and that tends to be very difficult for us to manage. If we can empathize actually with our patients right now, 6 to 20 symptoms is really affecting their quality of life. We do know also that dialysis in and of itself doesn't actually improve a lot of the overall symptom burden for many patients. So the actual act of dialysis or cleaning the blood doesn't tend to overall change those number of symptoms that our patients have. So Many patients still feel tired, and I think you guys mentioned that in the chat. 1 year after dialysis was initiated, only 24% of patients had reported improvement in this study that was on here with the references below. Dialysis actually itself may cause patients to feel more tired or washed out. Pruritus, again, the itchiness of the skin, is 20% across patients who have chronic kidney disease, and up to 84% of people undergoing dialysis. So a lot of our patients, if not almost all of our patients, will experience this. Sleep disturbances, so more common in severe patients with dialysis compared to those before they started. So again, this is something that's quite important that we begin to assess well and support our patients with. Pain, 1 year after dialysis was initiated, 26 patients reported improvement, and 28 reported worsening. And again, also sexual functioning. So there we can see 30% reported worsening 1 year after dialysis was started. So although dialysis is a very important aspect of the care that we give to our patients, we do need to acknowledge as clinicians that their symptoms are going to stay the same, if not worsen, while they're on dialysis. And it is quite important as we do this course that we find ways to acknowledge and to come up with a plan to support our patients in these symptoms. So here is Dr. Sarah Davidson. She's the head of the Kidney Supportive Care Working Group at the ISN, and she's based in Canada, and she's one of the leads in the academy for the course online. So she said, in terms of our treatment goal, we need to find ways to ameliorate pain that is affecting a patient's quality of life and or their function, but it's not always necessary or possible to resolve it completely. So we need to address it. We need to ask our patients about their pain and their symptoms. We need to help them identify how to score their pain and their symptoms so that we can compare from 1 week to the next. But it isn't, unfortunately, always possible for us to resolve it completely based on their disease and also the treatment modality. You mentioned most of these, but again, even in post-dialysis, patients experience side effects from the treatment. The low blood pressure, muscle cramping, nausea and vomiting, the headache, back pain, which is what most of you mentioned as well, fatigue. And we also know that people can have complications, their loved ones can have burnout, and often there's a major financial cost to having dialysis. Even if you're on NHIF, it financially affects many of our patients. So we're going to think of a patient, Mr. Majuma. He's 66 years old. He's a retired businessman, and he's diagnosed with diabetes, as well as chronic kidney disease 5 years ago. He is one of a hypothetical, he's not a real patient, hypothetical patient at our clinic who goes to our AHN clinic twice a week. He complains of chronic back pain, persistent itching all the time. So persistent means all the time, but he also has said it's all the time. And sometimes it's actually very severe. He has severe diabetic neuropathy. So this is a type of pain that's common in people with diabetes. It is a pain that's often described as tingling, shooting, very common in the extremities and the fingers and the feet. And he is complaining of a burning sensation in both of his feet. So now I want you again to go to your chat, or if you are interested to unmute, you can also put your hand up and we can get you to unmute. I want you to think about the following questions. What would we do first with this patient? What would we first address? What would we first do as we begin our assessment? Second, how do we identify what is most important to address? What is the most important symptom to address in our patients? And then in your practice, I know we have some nurses on the call. It looks like we have some trainers. I saw Dr. Mazar joined us as well. What medications would we prescribe for a patient in severe pain with kidney failure. So in this particular situation, we are looking at the neuropathy or the neuropathic pain. So what would we do first with a patient like this? Seems like we probably know this patient. They've been on, they've had chronic kidney disease for 5 years. So chances are they've been on dialysis for at least a few years. He's 66. Seems like a pretty standard patient that we would see, has a few comorbidities. Perfect, SIFA. So we definitely first identify any reversible symptoms. So what were the main symptoms that the patient had reported? We can also definitely first counsel the patient on the condition. So we try to understand, what does the patient know about their condition and what do they expect? Yeah, that's really important. Really good, Anson. So we need to assess the severity of their symptoms. That's the first thing we need to do. Most of these symptoms are subjective. So when we think about symptoms, there are some symptoms that we can assess doing blood work. We can diagnose someone with anemia based on blood work. We can diagnose someone with hypotension, so low blood pressure, based on their blood pressure score. But most of these symptoms that we're talking about today are actually self-reported. So Anson is definitely correct. We need to identify how bad is the symptom, or how severe is the symptom for the patient. Is the symptom mild, so it's not so bad, they're able to cope, or is it the worst symptom they've ever experienced? Therefore, for example, in this case, the neuropathic pain, is the neuropathic pain preventing Mr. Majuma from walking? Is it preventing him from eating? Really, really important. Good response. So try and seek and sort the underlying cause. Okay, so in this situation, we identified pruritus, so itchy skin. They also said they have nerve pain. So what would the underlying cause? Okay, they talked about back pain, itchiness, and nerve pain. So what is the underlying cause of nerve pain? Jefferson, do you want to respond to that? What is the underlying cause of nerve pain? Yes, very true. So Jefferson, it is caused by diabetic neuropathy. So it's actually caused by the diabetes itself, and it isn't necessarily a condition that we can reverse. It is definitely the underlying cause, but we do need to treat it, and it will need to be treated most likely for the rest of the patient's life. Uncontrolled diabetes, for sure. Often damages nerves. So in this situation, we first want to assess the symptoms. We want to identify what we can reverse. Maybe the chronic back pain could be due to him feeling quite uncomfortable in the dialysis chair. So something very simple is we could recommend using a pillow. We could also ask the patient how their bed is at night. Do they have a specific chair that they sit in that's causing them pain? Potentially the patient needs to have starting on a non-opioid for the chronic back pain that they are experiencing. We identify the most important symptom to address in our patients by asking them. Although that's a very simple answer to that question, if we don't ask our patient what's the most important symptom that we address, we might focus on the neuropathy, where actually the itchiness is the most important symptom to our patient, and we actually didn't really address that at all. We can assume that pain often is the most important symptom, but we need to make sure we ask our patients, what's the most important thing that we can do for you today to address the fact that you're not, that you're having a very distressing symptom. All right, the last one. What medication do we often prescribe for people in severe pain, and we'll focus on the nerve pain. What are some common medications that we prescribe or we work together as a team to recommend for our patients when they have neuropathy? So what's available in your area? Do you work with the diabetic specialist? Do you work with a pain specialist? Do you, as the medical team, are you able to prescribe medications to address nerve pain? I know some of you would probably be working with clinical officers or even the medical director.
The common drug that you use for patients who have leg pain, that is diabetic neuropathy, common drug that you take from the pharmacy. Sometimes patients are short of it, or if the stocks are over or supplies are over, and then you need to get a very common drug.
Yeah. So we also have a few comments into the chat: gabapentin, pregabalin, amitriptyline. Very good. Pregabalin. So most, if not all, if I'm not mistaken, these would all need prescriptions. And I think that one thing at AHN, we need to make sure we are consistent with. We need to ensure that we empower our patients to get prescriptions for their medications, and then also we can repeat or refill prescriptions. So this patient most likely would need a nerve pain medication that would target the pain that they have. We would need to assess their pain regularly and then repeat their prescriptions, because even after a 2 to 4 week trial of these medications, the cause of the medication we cannot necessarily alter. We cannot cure their diabetes. We can encourage them to have better control over their diabetes. But the nerve pain will be something that we will have to treat long-term. So we will need to identify that. We can reassess that. We might be able to reduce the dosage if we're able to manage. Usually tramadol we would not use for nerve pain, maybe for the chronic back pain, depending on how severe the pain was for the patient. But yeah, very good. Okay, so what we will do now is we will look at a few of our symptoms. I'm conscious of the time. We have another 10 or 15 minutes. So we'll probably get through the first few, and then we will continue on next week. Okay, so this is the way I have set up the presentation for today. I have shared the slides on iEcho, but for each symptom, you will see a chart here. So our first symptom is uremic pruritus. On the very far left-hand side, it will identify what we need to look for as clinicians and what we need to correct. So these are some of those underlying or reversible things that we can address and identify. The next column, again, first we were supposed to recommend and try non-pharmacological measures. So those are things that are not necessarily medication focused only. And then our last column would be the pharmacological or the drugs that we usually recommend. So because these are in slides, this could be something fairly easy you could print out and keep on your unit if there's some specific symptoms that you regularly come across and you want an easy way to address them. It is a bit overwhelming when it comes to symptoms because there's a variety of ways to treat symptoms. Sometimes certain things work for some patients. Sometimes it doesn't work for other patients. So we don't expect you to memorize this. This is not something that you need to memorize. This is something that you need to know where to look for accurate information quickly so that you can address a symptom on the same day that the patient has told you about it and be confident that you can follow up with it. So this is the way that we're going to go through the next several symptoms. So again, if you are able to print this out or you want to take some notes, then you can format it this way. So uremic pruritus, so itchiness in the skin. This type of symptom is non-histamine dependent. So oftentimes when we have patients that come to us in an outpatient clinic or not necessarily at AHN, When someone is complaining of itchy skin, we often do recommend an antihistamine. But with our patients, the cause of the itchiness is not going to be affected by antihistamine drugs. So it is not antihistamine dependent. So therefore, antihistamines won't work for these patients. First of all, we need to look for and correct that the patient is having adequate dialysis. We also could understand their PTH, their calcium, as well as their phosphorus management. We then can look at if they're having any drug reactions or their iron deficiency. Some of our patients will come to us before they've had dialysis and actually have allergies, or they have a history of dry skin or inflammation. So these are things that we can address, and we can definitely potentially treat directly. We do, when we recommend and we talk to our patients, we want to, as much as we can, encourage them in a sensitive and compassionate way to minimize the scratching, and also not to use hot water when they're bathing. So to use lukewarm or cool water, and also to use gentle soap. When we do non-pharmacological approaches, we want to keep their skin as hydrated as possible. So general pruritus care is recommended. So using moisturizers is really important. I know in Kenya, and I also assume in Tanzania and Rwanda, probably the phototherapy is not something we have access to, but this has been shown to be very effective for patients, and also some complementary therapies. In terms of medications, we recommend a moisturizing cream that includes 0.3% menthol, peroxamoin 1%, or also a combination of the menthol, camphor, and phenol. A very good cream is also really important. So if a patient is able to access Vaseline, that can also help a lot. We need to put it on regularly. There's also been shown to have good effect of capsaicin cream. If a patient is extremely uncomfortable related to the pruritus, we also could recommend gabapentin or pregabalin for our patients, and then the dosages are there as well. So these are some recommendations. Again, this list is not necessarily to be memorized. We do want you to use best practice, and sometimes things change. So make sure you keep these recommendations easily accessible, where you can review them based on the patients that you're seeing. All right, now on to restless leg syndrome. I think you guys had mentioned in the chat, and I know this is a very common symptom for our patients in the dialysis units. So first, we need to look for and correct any iron deficiency anemia, less than 50 to 75 grams per milliliter, and then we need to treat that. We also need to address any hyperphosphatemia, and then again, any adverse reactions to drugs. So there we have a list of things that people may have reactions to. We know that in terms of non-pharmacological, reducing alcohol or abstaining from alcohol, caffeine, and nicotine can help reduce the symptom for our patients. We know also that many of our patients are middle, if not older age. So abstaining from behaviors such as this may be difficult for our patients, but we can kindly and of course compassionately encourage them. And we know that doing distraction techniques such as solving problems or having board games can also help our patients refocus and not necessarily focus on the restless leg. Doing exercises during dialysis, there have been some interesting studies to show that that can also help patients who have restless leg syndrome. So that would be a small pedal that would be put at the bottom of a patient's dialysis chair, and that has been shown to reduce the restless leg symptom that many of our patients experience. We do need to first also rule out any leg cramps, osteoarthritis, that neuropathy, any of the skin itchiness or pruritus there as well. In terms of ways to treat it, again, here is a list of some recommendations. gabapentin, pregabalin, and a few others there. I'm not sure all of those are accessible. And if there is a medication that you see on this list that is not necessarily accessible, we can make note of it. This was from the team in India, so we may not actually have access to all of the drugs that they do there. So back to the Academy, so the International Society of Nephrology also identified restless leg syndrome. They have a whole module just to focus on that, identifying that the iron levels were a contributing factor, as well as some medications. So these are some things we have mentioned in the previous slide. While restless leg has its foundations in reduced brain, if not systemic iron levels, experts in restless leg recommend giving oral supplementation if the iron stores are low. So this could be done by giving ferrous sulfate 325 milligrams with vitamin C, 100 to 200 daily to aid in the absorption of the iron. Intravenous injections of iron statistically showed improvement over a placebo, but the effect was faded after 4 weeks. And there's the resources under that slide. Some of the non-pharmacological treatments that ISN recommends, we've mentioned, but also some relaxation techniques, exercise, gentle massage, good sleep hygiene. So ensuring that our patients have good sleep routines can be really important and effective as well. And there's the medications that were recommended previously in the slides, the gabapentinoids. So in conservative kidney management, so that would be when a patient is not on dialysis, but we are still supporting them with their kidney failure, it would be gabapentin 100 milligrams with pregabalin, up to a maximum dose of 300 gabapentin and pregabalin 75. For our patients on hemodialysis, we would give it, the conservative kidney management, this would be each night. For our hemodialysis patients, we would give it after each dialysis treatment, so twice a week after their treatment. And peritoneal dialysis, we don't have that, but it can also be given for those patients. And then again, a few other recommendations of dosages for other medications. So we'll end our session and leave a few minutes for questions, and we'll end it with nausea and vomiting. So when we think of our patients that are experiencing nausea and vomiting, first we need to control any uremia or selectoremia. Sorry, it's a difficult word to say. Any side effects of opioids. If any of our patients are on a low-dose opioid like morphine, we know that nausea and vomiting can be a side effect of that medication, as well as SSRIs. So we do need to identify and see what medications our patients are taking, as well as if patients have any delayed gastric emptying due to their uremia or diabetic autonomic peripheral neuropathy. We also would need to make sure we address any constipation, because this could be causing the nausea and vomiting that the patient's experiencing. So using things such as relaxation, ginger can be some non-pharmacological ideas of how to support our patients with this, as well as avoiding spicy or greasy food, again, based on patient choice. When we think of medications, we can consider metoclopramide, 2.5 milligrams orally every 4 hours if gastric paresis is suspected. And then on danzatron, 4 milligrams 3 times a day, up to 8 milligrams. But we do need to know that if our patients are constipated, we should avoid ondansetron. And then a few other recommendations for nausea: haloperidol and olanzapine. Again, looking at your dosages, especially taking into consideration our patients with kidney failure. So next week, we will continue to talk about a variety of symptoms. We will look at dyspnea, depression, cachexia, and pain, abdominal pain. and we will continue with that next week. Does anyone have any particular questions about this, or even going back to our patient earlier, the patient who had chronic back pain, pruritus, and neuropathy? What now, based on some of your ideas, what could we do for our patient who, what could we do to address the patient's pruritus? I can put up the screen again so you can see the case. So it was Mr. Majuma, 66-year-old. He was retired with diabetes. He's had chronic kidney disease for 5 years. And he's on dialysis twice a week. Persistent itching all the time. He also has severe neuropathy. So we could definitely begin to understand what is the cause or what's the pathogenesis, as Nakwir said, of the patient's pruritus. Could it be because the patient has dry skin to begin with, previous to their kidney disease, or is it related to their treatment? What do you often do, based on the fact that this is a pretty common scenario, what do you do at your clinic to treat pruritus? It's quite a common symptom. And I assume with the number of patients we have at AHN, we probably do address pruritus. What are your thoughts? Sifa, what do you normally do? Do you teach about pruritus in your training course?
Hello. In our training course, among the dialysis complications, we do teach pruritus. Yeah.
And what do you guys normally recommend?
Okay, in recommendation, mostly we do assess the adequacy of dialysis that our patients are receiving. If at all, if this patient have access flow issues that affect the dialysis that he or she is receiving, so we do assess. If the access is causing the poor flow that will lead to poor inadequate dialysis, then we do rectify. Also, we look into if any drug that there is any drug that is affecting the patient, and also if at all the priming, we do put emphasis on the priming procedure. If some of the products within the blood tubings are affecting the patient, so we do the corrective priming. Yes.
Thank you. Yeah, so making sure that we identify that their dialysis and their protocol for their dialysis is at the best possible level is really important, as you were saying, making sure that they're getting good treatment, their flow, their access. So if it wasn't related to one of those things, or even if it is, what are some things we can recommend to our patients when they're at home to address the itchiness?
When they are at home, we do teach our patient that they should not aggravate the itchiness by either consuming certain medication that they aren't prescribed with their physician, and also they should apply the non-pharmacological methods that is keeping their skin hydrated, things like that. And also they should communicate with the physician for further management. Yeah.
Yeah, so definitely encouraging them with the hydration, the moisturizer, letting us know if the symptom continues to worsen.
Yeah.
Yeah, Dr. Mazar has written in, he goes through a process of checking for xerosis, and then some of the blood levels, and then suggesting treatment accordingly. So it's really good. So we need to be, again, as we mentioned earlier, we need to be stepwise in our approach. If a patient has identified a symptom, we need to be very thorough in how we address it, and then come up with, realistic goals of how we're going to treat the symptom. Okay. Oh yeah, go ahead.
Sorry, would anyone give a non-steroidal anti-inflammatory drug to a patient with CKD in pain? That's brufen, ibugesic, these drugs, diclofenac. So these drugs are to be avoided because you see the cause of the pain is neuralgic, okay, and even if there is an indication in these sort of patients, these drugs ideally should be avoided because they damage the residual kidney function. It's very important not to give these drugs. In fact, some of these patients may be given these drugs from home. You see, they may be carrying these drugs. It's very important not to give non-steroidal anti-inflammatory drugs in patients with pain because they destroy the remaining nephrons that are present. Now, there may be 1% of the kidney is working. Now, even that 1% will be destroyed immediately by taking these drugs. So never give non-steroidal anti-inflammatory drugs in these patients with CKD, even on dialysis, because that will destroy the residual kidney function. Thank you.
So for this patient, if he had chronic back pain, chances are many patients that don't have kidney disease would be prescribed a short kind of protocol of non-steroidal anti-inflammatories, or when the pain gets worse, they would take some from their local chemist. And I think what Dr. Lloyd is saying, that even when our patients, we may have mentioned it to them or we recommend it, they still oftentimes will want to address a symptom. So they'll want to address a pain that they're experiencing. But really remembering and finding ways to encourage our patients to let us know what medications they are taking, and also the specific ones they should really avoid to prevent any worsening of their kidney function. Okay, so unless there's any further questions, we will, there's a few more messages in the chat. Advise patient to check their diet, to avoid foods that are high in phosphorus, really good, and engaging the nutritionist for the uremia, very good. So we'll end there for today. Next week, we will continue with the rest of the symptoms. And yeah, please come to the session just as you did this time. It was great to meet you all. If you are able to keep your video on, great. If not, that's okay, we understand. And don't forget your notebook and a pen, and we'll be reviewing the content together as we go through. Thanks, everyone. And if you do need to reach out to me, or you do have a patient that is quite complex as we go through the course, please know that I am around. I'm based in Nairobi, but I'm available by WhatsApp or email. So please reach out, and yeah, we'll see you guys next week. Thanks again for joining.
One small input. I think, if you go to the clinical side and you see patients in pain, think of these things and come back and discuss. You see, it helps. It helps you to learn and come back, ask Erin questions, ask us questions, and take up the onus to manage patients now on the at the bedside. Okay, very, very important. Take the onus. Now you've gone through something. Go read up, come back and ask questions, and that's how you actually learn a lot and become a leader in the domain with time. Okay, so that's very, very important. So it depends on the initiative you take in looking after your patients. Thank you.
Thanks, everyone. Have a good afternoon.